Welcome to Eurofins ViraCore webinars. Today's webinar is the practical use of CMV inSIGHT, or the CMV T Cell Immunity panel, in the lung transplant recipient. We have with us Dr. Christina Doligalski. She is a cardiothoracic solid organ transplant clinical pharmacist practitioner at UNC Health in Chapel Hill, North Carolina. She serves as a program director for the solid organ transplant pharmacy residency at UNC and Chapel Hill, and is an assistant professor of clinical education with the UNC Eshelman School of Pharmacy. She's been in practice as a cardiothoracic transplant pharmacist for nearly 15 years, with a variety of peer-reviewed publications, primarily focusing on the optimization and individualization of pharmacotherapy for the transplant recipient. Please stay for Q&A at the end, and feel free to put your comments or questions in the chat box. Take it away, Dr. Doligalski.
All right, Dave, thank you so much, and thank you for having me here with you all today. I'm really excited to share some cases of patients that I've personally been involved with, their care, and how we were able to individualize and optimize their therapy utilizing this assay. So as many of you are likely aware, CMV in our lung transplant recipients really is a challenging complication. Our lung transplant patients are among the highest risk for CMV disease, morbidity, and mortality after transplant. This is due to a variety of factors, including the high degree of lymph tissue transfer within the lungs themselves, the high degree of immunosuppression that these patients require after transplant, as well as a risk for hypogammaglobulinemia, which we know is a risk factor for the development of CMV. With that comes along substantial morbidity and mortality at its highest really in our lung transplant, and of course our small bowel transplant recipients. Because of this, various consensus guidelines recommend the use of universal prophylaxis in all lung transplant recipients for a minimum of 6 months. However, we're going to talk a little bit about the duration of that and how there's some question marks about how long we should be prophylaxing these patients. But we know that they are at quite high risk and need protracted prophylaxis. So one of the newer assays or tests that we have to help us in our battle against CMV is the T Cell Immunity test. And so for those of you who are unfamiliar with this assay, we essentially take whole blood. It is stimulated with both CMV antigens as well as SEB, which is a monovalent T cell mitogen. That's really going to stimulate all of our immune system response as well as an unstimulated control. And with that, we are able to recover and stain cells for both CD4, CD8, as well as a variety of other surface markers to analyze via flow cytometry what the actual response to that CMV antigen is in both our CD4 and CD8 cells, and compare that to kind of background overall immunoresponse with the SEB testing. If you'd like some more information on how the actual assay is run, definitely reference the Eurofins ViraCore website for some more detailed information on that. But the benefit of this assay, or the theoretical place in therapy, is really going to be in predicting or showing what that protective immunity to CMV is moving forward, and not just reflecting what someone's past exposure to CMV is like, which is really what we have with the CMV serostatus with our IgG responses to CMV. So can this tool be used to help us better care for our patients proactively in the post-transplant period? So the first case that I want to share with you is a 70-year-old male patient who is high risk for CMV, so donor positive, recipient negative. He received a bilateral lung transplant for interstitial pulmonary fibrosis. As per our center protocol, he received basiliximab induction and then was maintained on tacrolimus, mycophenolate, and prednisone, and then of course received valganciclovir for primary CMV prophylaxis. His post-transplant course was reasonably uncomplicated. As expected, he developed type 2 diabetes. He also developed some chronic kidney disease, and he unfortunately developed COVID a couple of times post-transplant. Now, he had no rejection or significant infectious complications outside of that. And so then the question becomes, how long should we continue his primary prophylaxis in this high-risk recipient? Well, if we reference our guideline works, the more recent one being the 2019 AST Infectious Disease Community of Practice guidelines, they recommend that antiviral prophylaxis with valganciclovir be completed for at least 12 months, which is a strong recommendation. And some centers will prolong that prophylaxis indefinitely. And if you're like me, you've seen that practice happen at various institutions where there's a hesitancy to want to discontinue primary prophylaxis, especially in someone that may be perceived to be at a higher risk for CMV primary infection in that high risk recipient population. And so this was that case. This was a case like that. This patient received continued primary prophylaxis. And around the 2-year mark, at that point, he was on tacrolimus with a goal of 6 to 8. Mycophenolate was dosed at 750 milligrams twice a day and prednisone at 7.5. So pretty consistent immunosuppression for what we would expect for someone around 2 years out from lung transplant. And at that time, we proceeded to complete a CMV T Cell Immunity panel to see what would happen for this gentleman if we were to stop his valganciclovir prophylaxis. And so what we noted is that even though he had an adequate kind of overall immune response with his SEB values being adequate, his both CD4 and CD8 CMV responses were low or below the threshold of the 0.2 that we would consider to be adequate protection. And despite all of this, he had an adequate absolute lymphocyte count, which is another non-specific marker that some centers may use to determine whether or not they could stop CMV prophylaxis. And so based off of these results, we continued his valganciclovir prophylaxis. Now we move forward 1 year. He is still on his valganciclovir's primary prophylaxis. However, we have modified his immunosuppressive regimen. So his tacrolimus goal has been decreased because of continued renal dysfunction. His mycophenolate dose has been decreased as well as his prednisone dose, given that he's done well this far out from transplant. And we repeated the CMV T Cell Immunity panel. And you can see now that those 2 markers of CMV immunity, his CD4 and CD8 counts, were adequate. Despite the fact that his absolute lymphocyte count was still kind of low normal, so it was 0.9 at this check. His valganciclovir prophylaxis was discontinued, and we initiated weekly CMV monitoring just to be extra sure that he's not developing CMV infection after discontinuation of valganciclovir. And up to the 4-week mark after discontinuation, he did not have any CMV. Now, it was around that time that he presented to the emergency room at week 5 with a 2-day history of shortness of breath, fatigue, fever, and chills. Unfortunately, he was diagnosed with his 3rd case of SARS-CoV-2 or COVID. He also had a new oxygen requirement and also presented with an acute kidney injury on this admission. And so he was admitted, he received remdesivir and supportive care, but the renal dysfunction persisted. They actually performed a renal biopsy and identified that he had secondary FSGS, as we have seen in some of these COVID positive patients, and was started on high-dose corticosteroids. Now, around that time, or following the corticosteroids, someone said, we should probably check a CMV PCR. We did. It was low positive. It's hard to tell whether or not he had symptoms because he, of course, has COVID symptoms. But that was repeated 5 days later, and he had active viral replication, and treatment was initiated with IV ganciclovir for him at that time. And so as we were wrapping up that admission, really the consensus was the CMV reactivation really was thought to have occurred in the setting of this critical illness, an acute COVID infection, as well as the high-dose corticosteroids that were required for treating his FSGS. So some of the things that I took away from this case, and I really like that we had the progression of one assay for him at the 2-year mark, another one at the 3-year mark, and then seeing what happened, is that a CMV T Cell Immunity panel did confirm that continuing primary prophylaxis in this high-risk patient population is often needed. In our own cohort or in our own experience, We have checked CMV T cell assays in 16 high-risk patients around that 1-year mark, and 11 of the 16, so almost 70%, did have a poor response. And so this idea that our high-risk lung transplant recipients may need more than 1 year of primary prophylaxis is supported by this data. The second follow-up that we have to that is with immunosuppression minimization, the CMV T cell response improved, and we were, I would say, successfully, with that asterisk of what occurred later, that prophylaxis was able to successfully be discontinued. And I think this is a really important point to think about. What have you done with someone's immunosuppression, whether intensifying or minimizing that? And can you consider immunosuppression reduction and serial testing of a CMV T cell assay to determine whether or not someone needs continued antiviral prophylaxis? And then finally, and this is, I think, a really important point across the spectrum of CMV, is that concurrent illness, hospitalizations, or any need to intensify immunosuppression is likely going to affect an individual's CMV immunity. And so this is a situation where either considering empiric reinitiation of CMV prophylaxis or more intensive monitoring with a preemptive approach may be beneficial in those severely ill patients or in those receiving high-dose corticosteroids for whatever indication that may be. So moving into our next case, this is a 71-year-old male who was also CMV high risk, and he received a bilateral lung transplant for inhalation injury, and he was 6 years post-transplant when we are meeting him now. His transplant initially was complicated by 2 episodes of rejection early after transplant. He also has known coronary artery disease, and then he had both a CMV syndrome and CMV colitis episodes that occurred within those first 3 years. At the time, 6 years after transplant, he is on tacrolimus with a goal of 5 to 7. Mycophenolate is at 750 milligrams twice a day and 7.5 milligrams of prednisone. And like many of you who have cared for lung transplant recipients chronically, you notice that there are oftentimes when someone has 1 or 2 CMV reactivations and they end up committed to valganciclovir or antiviral prophylaxis because you're just so nervous that they may have another episode of CMV. And that was the case for this gentleman. He had been maintained on valganciclovir since his last CMV reactivation. So the question of secondary prophylaxis and how long that should be continued is really an area of debate, I would say, as well as an area of limited data of what we should do for these patients. So in general, secondary prophylaxis to prevent CMV relapse is not recommended as routine practice, but then I have highlighted, but may be considered in a subset of high-risk patients. And I think many people would agree a high-risk lung transplant recipient falls into that subset of a high-risk patient. And so this was a gentleman where we obtained a CMV T cell assay and demonstrated that he actually had really good immunity or had adequate immunity per the assay, that he should be able to discontinue prophylaxis and would stay CMV free. And that was exactly what happened. We discontinued his valganciclovir, and as of 400 days now later, he has had no CMV recurrence. And so I think the takeaways that I have from this are utilizing the CMV T cell immunity panel in situations of secondary prophylaxis. Many times CMV disease or disease recurrence can, in practice, commit patients, especially lung transplant recipients, to prolonged secondary chemoprophylaxis. But we know that CMV exposure and memory responses can develop after transplant. In the 15 patients that we had at our center in this very same scenario of a protracted secondary prophylaxis scenario, nearly half of them had a CMV T cell immunity panel drawn, and almost all of them, 6 of the 7 of those, remained CMV free following valganciclovir discontinuation. So this is really one of those situations where you can kind of de-prescribe for patients where maybe that question hasn't come up recently of do they really need this valganciclovir. If you're not having leukopenia that's prompting a discussion or review of their medication list, this can be an easy thing to forget about, but really one where I feel like we have a lot of opportunity to intervene and avoid medication exposure and the potential for drug resistance in patients who really don't need this because their own immune system would be able to handle this. And so CMV T cell immunity panels early after treatment for CMV disease in a patient with stable immunosuppression, and I put that clause in there based off of our previous cases, you know, if you've got someone that you're not intensifying their immunosuppression, that really can help minimize unnecessary medication exposure for those patients. And then our final case that I'm going to talk about today, we have a 40-year-old moderate risk lung transplant recipient, a female who received a lung transplant for pulmonary hypertension. And she presents to the emergency room for acute worsening shortness of breath and hypoxia at home. And she is around 2.5 years out from transplant at this point. The concern was for rapidly progressive CLAD in the setting of multiple recent community-acquired respiratory infections. We have been monitoring her very closely as an outpatient, and her lung function had continued to decline. And following much other testing that we're not going to talk about in the course of this webinar, we ended up proceeding with alemtuzumab and high-dose corticosteroids to treat that progressive CLAD. And because of that, then antiviral and antifungal prophylaxis were resumed per our own center-specific protocol. And our practice has been to do that until their absolute lymphocyte count is greater than 0.5. She then presents back to us 6 months after her alemtuzumab administration and is asking if her medication regimen can be de-escalated in any way because her medication costs have increased dramatically. And she has really having a hard time covering all of her medications. Unfortunately, over the last 3 checks or so, her absolute lymphocyte count has varied between 0.3 and 0.5. And so if we were using that as our sole marker of whether or not we could continue or discontinue prophylaxis, we would feel pretty hesitant to discontinue prophylaxis. When we look at what the guidelines suggest for us to do for prophylaxis following T-cell depleting therapies in our lung transplant recipients, they do recommend that we begin antiviral prophylaxis when anyone receives any lymphocyte depleting antibodies, which would include alemtuzumab or antithymocyte immune globulin, but that the optimal duration of that antiviral prophylaxis is really unknown. They recommend anywhere between 1 and 3 months, but we know that a medication like alemtuzumab is going to have a very protracted lymphocyte depletion for our patients, as demonstrated in this case. So at that time, we obtained a CMV T cell immunity panel and were able to demonstrate she had adequate immunity. Her valganciclovir prophylaxis was discontinued and serial monitoring of CMV PCRs was initiated. And with greater than 120 days of follow-up, she also has not had any CMV recurrence. And so from this, we know in an area where there is very little guidance to describe the optimal duration of antiviral prophylaxis following a T-cell depleting therapy, and where non-specific markers such as ALC are inadequate to describe the risk of CMV recurrence, this really could be a great opportunity to utilize a more specific assay like the CMV T cell immunity panel. In our own center, one of the analyses that we looked at when we kind of looked at our cohort of everyone who's had a CMV T cell immunity panel done, we looked at those that had an ALC that was considered adequate, so that greater than 1. And then we also looked at those where an ALC was considered inadequate or less than 1. And interestingly, 8 out of the 10 lung transplant recipients who had a T-cell immunity panel obtained for any reason, even though they had an ALC over 1, they had a poor response, and prophylaxis was not discontinued in those cases. Whereas 4 patients out of 7 who had a poor ALC actually had an adequate response and were able to successfully stop prophylaxis. So utilization of ALC alone as a marker really doesn't seem to be as helpful as pairing that or using data such as the CMV T cell immunity panel to help be more specific in our assessment of someone's immune risk. So closing all of this out and thinking about this together, we know CMV is a potentially life-threatening complication of lung transplant. And many of our lung transplant recipients are going to require either extended prophylaxis, extended treatment, or may have these very complex cases of CMV where more fine-tuned information would be needed or helpful. In those situations, I think our CMV T cell immunity panels can be utilized in a variety of scenarios, both duration of primary prophylaxis, duration of secondary prophylaxis, as well as following treatment of rejection episodes to individualize and guide therapeutic decision making. And with that, I look forward to answering whatever questions you have.
Well, thank you, Chrissy. I think that was a very insightful talk and extremely helpful for our viewers. We will be taking questions and answers now. I'm going to start you off with one that I have, if you don't mind. In which clinical scenario have you found CMV inSIGHT most helpful?
Yeah, I presented 3 cases that really were the majority of the types of question or types of clinical situations that we've used them in. I find that discontinuation of secondary prophylaxis has probably been the most clinically impactful to be able to show and really shift the needle of our practice of feeling nervous about stopping that secondary prophylaxis in a high-risk patient. Now, of course, taking into account a lot of other things like how reliable are they going to get follow-up, how clinically stable are they overall, if they were to develop CMV, how significant would it be for them? But I think that's probably the one area where I've found it most useful.
Okay, thank you. Well, that's great. Looks like we got some in from the question and answer section. This first one I'm just going to take myself. It's what's the turnaround time for the assay? It's 36 to 48 hours, just due to the way we run this on Flow. But what's your typical serial monitoring protocol after DC of antiviral therapy, Chrissy?
Right. Yeah. So our standard protocol is to monitor CMV PCRs weekly for 4 weeks, and then every other week for a total of 4 checks or 2 months. So 3 months of monitoring.
And that's after you've had a good T cell response?
Right now, we are still following a monitoring protocol like that, even in someone with an adequate CMV T cell response. I think the more experience we get with it, especially in a moderate risk recipient or in stopping a secondary prophylaxis patient, I feel like I would see us moving away from doing all of that CMV PCR monitoring. But I think right now, while we're still figuring out the advantages and pitfalls and the patients that we're using it in, we are still doing that monitoring. But for example, I used this last week in a patient who has been notoriously bad about going and getting lab follow-up. And so we got a CMV T cell assay. It showed adequate response. She was someone that we had been nervous to discontinue our primary prophylaxis in because she wasn't reliable about getting labs. And so using this, we said, hey, we can stop her prophylaxis. We'll get labs when we can, but we feel a lot more confident that we can remove this med from her regimen.
Okay, thank you. That's wonderful. So it looks like questions are just exploding now. We've got
Perfect.
So do you have a set time or do you have an initial CMV T cell immunity testing point for post-transplant?
Yeah, for our high-risk patients, we are checking it at the 1-year mark post-transplant. And then after that, have been checking it around every 6 months or so as we are changing immunosuppression or weaning immunosuppression. Now, of course, if we're having to intensify immunosuppression or if they're on the same immunosuppression that they were on at that 1-year mark, I may be deferring that out to potentially the 2-year mark or using that as a conversation point of, hey, do we need to think about decreasing their immunosuppression at all?
Okay, thank you. So the next one is, does the type of immunosuppression change the effects of the assay? And I think you've
Mm.
probably seen a little bit. I'll let you handle this one.
Yeah, absolutely. I think it's a great question. At least in the lung transplant patients that I've taken care of and in seeing in this assay in some of our heart transplant recipients as well, I don't really see a huge difference between choice of calcineurin inhibitor, choice of antimetabolite between azathioprine and mycophenolate. Of course, prednisone dose does seem to be important. The one unique aspect that I have seen is in patients who are on mTOR inhibitors, sirolimus or everolimus, that we know that there's that antiviral benefit of those agents. And one of the proposed mechanisms is an upregulation of your CD8 response to CMV with mTOR use. And so I actually have seen in a couple of assays some really high CMV CD8 response in patients on an mTOR inhibitor, which has been really cool to see in a lab assay what you know or what you think is happening pharmacologically.
Thank you. I really appreciate that one. So another one, has cost been a limitation to your institution or patient population?
Yeah, we have not had any cost issues. I think one of the things that encouraged our team to begin thinking about using this at kind of the 1 year mark or the 6 month mark is the cost of our CMV PCR assay has increased dramatically. And really, I think about 4 or 5 CMV PCR assays are all it takes to get to the point where you are using, you're meeting the cost of the CMV T cell assay. So our patients haven't had cost issues, and we haven't run into any issues that I've heard of, at least in the ambulatory setting.
Okay, thank you. This next one, do you time your levels based on TACRO trough versus peak?
Oh, that's a good question. We have been, I would say most of our CMV T cell assays have been drawn with their other kind of morning labs, but we have had times where we decided to get the test and sent them back down to the lab after clinic. And so that would have been at a peak. It would be interesting to go back and look at the timing and see if there's any correlation. I mean, we have a smaller sample, but I haven't specifically looked at that though.
I'll be honest, I don't think anybody has. So that's a very interesting question. Uh, Next, do you check IgG or more specifically CMV IgG as well? And do you know if those levels make a difference in clinical response, even if T cell activity is okay?
Yeah, our institution or program specific protocol is to monitor total IgG levels at least every 3 months in our very stable patients and monthly in our fresh transplant recipients. And we supplement with IVIG at a total IgG less than 500 unless they have an active infection, whether it be bacterial or something else. And then we supplement at less than 700. And so except in very rare instances where we have insurance denial issues for total IgG between 400 and 500, all of our patients are going to have a total IgG that's greater than 400 or 500, either through repletion with IVIG or on their own. And I have not seen, at least anecdotally, a correlation between total IgG levels and their CMV T cell response. Of course, those with really low total IgG levels consistently, we're often looking at, do we need as much immunosuppression, and can we consider decreasing that based off of their history?
Wonderful. Thank you. The next question, if you still have time.
Oh yeah, absolutely.
All right. Wonderful. So how long after treatment and resolution of symptoms are you checking the T cell immune response?
Right. For me, many of those patients that we had done secondary prophylaxis, assessment, were folks who I like to say had been like stuck on secondary prophylaxis for a while. And but since that time, and since the great response that we've seen using that, I'm typically going about 2 to 4 weeks afterwards. I think our center particularly leans more towards secondary prophylaxis, and so I would rather ensure that folks are stable on stable immunosuppression, and then check so that we can have a nice, good, durable discontinuation. But I think that I would feel comfortable doing that within 1 to 2 weeks of their second negative CMV test to assess what their immunity looks like.
Thank you, Chrissy. Appreciate that. So let's see here. I think we've got one more on the bottom at least, and they keep coming in. Regarding the 16 patients with the CMV CMI checked around year 1, were they all on valganciclovir primary prophylaxis patients? That's the first part of it.
They were. There may have been one letermovir patient, but I'm pretty sure that there was not. I think that they were all valganciclovir patients.
Okay, that answers the second question. And then, would you expect the findings to be different at all? You know, if there were no letermovir, or if there were letermovir patients in that group that you think maybe didn't have them?
Right. Yeah. And I think this is an area that once we have more exposure with letermovir, we're going to start seeing some really interesting things. Unfortunately, in all practicality, for lung transplant recipients, I mean, most insurers are not covering letermovir for lung transplant for primary prophylaxis, or even if they are, the copay is quite expensive for some of those patients. And so I don't know that we're going to get as much experience with letermovir primary prophylaxis in lung transplant as what we'll see coming out of kidney transplant. So that will be nice, but I do wonder if the small amount of viral exposure that you do have with a letermovir might allow for kind of that idea of controlled exposure and then better immunity at the 1-year mark. So it would be interesting to know.
Thank you for that, Chrissy. And then the question that just came in as you were answering that question was just about that. So I think you've answered that one extremely well. So let's see. A lot of letermovir questions. We've got another one here. If you have a positive T cell immunity test in a high-risk patient, do you follow a standard repeat at 6 months or defer?
I have not been repeating a CMV T cell assay in someone who shows an adequate response. We discontinue prophylaxis and then they have no recurrence or no primary disease if it's a high-risk patient stopping primary prophylaxis. The only times that I've been repeating them or serially monitoring the CMV T cell immunity panels have been in situations of, you know, they didn't have an adequate response, we're modifying immunosuppression, let's repeat again to see if we can get them off of prophylaxis.
And, you know, if I could add in, work with a lot of the programs across the U.S., I think most programs are doing just what you're doing, Dr. Doligalski, as far as that goes. So, you know, very few repeat. I think the repeaters are typically the people that start utilizing this, but they don't have faith in it, and they want to make sure that they're seeing durability in these responses. And then once they see that that's the case, then they stop doing it. So thank you for that answer as well.
Yeah.
There was a question about CPT codes and is it reimbursable for CMS beneficiaries? Yes, there's a CPT code, billed times 4, and this is covered by Medicare. It's extremely rare for us to have any pushback. If we do, it's typically not due to reimbursement, but more towards a coding issue. Figured I wouldn't give you that one.
Thank you.
And then I think there's a question about, it says, we appreciate your experience in cases. Are there any trials in place to examine this further? Yeah, I think we have several things in the works right now that will further, dig into these areas. And also, if you go to ATC, I think there's a couple nice posters as well that you can check out. So take a look into that. And I'm going to go back and make sure I haven't missed anything. While I am going through these, Doctor, would you mind answering another question? So how has CMV inSIGHT changed the way you address CMV treatment and prophylaxis? I think you've
I
kind
think
of
as far
overviewed
as, yeah, I think as far as how we treat CMV, has really helped in understanding the need for secondary prophylaxis, really addressing, maintenance immunosuppression. What are we doing? Can we put that person on an mTOR inhibitor? Probably a lot less so in my lung transplant recipients. Do we explore that route? But more so in my heart transplant recipients, where they may have a lot of other reasons to consider an mTOR inhibitor. For prophylaxis, I definitely think having it adds this other really nice tool into the tool chest of what we already have, where you can take all of those pieces, put them together, and say with a little bit more surety what you think may happen if you take different approaches to that patient's care, if you continue prophylaxis, if you stop it. So I think that's what it has allowed us to do.
Thank you. I think that's very helpful for everybody on the call. There's a question that came in that asks, will you be at ISHLT?
I wish I was going to Prague. Unfortunately not.
Yeah, I think a lot of us feel the same way. I will say that we will have a couple people in attendance at ISHLT if you want to meet up with them. If you have interest, feel free to put your name and contact information in here and we can reach out to you. Another question. These questions are on fire today. Hot topic, right? So in our positive patients with a positive CMV T Cell Immunity panel, does your viral load threshold to initiate treatment change?
Oh, that's a really good question. It has changed. It would, in my mind, change that approach. I think, we have tried, and this is, a lung transplant thing, right? Like, we've tried to follow guideline recommendations of waiting until PCRs are at 1500 or truly seeing that 0.5 to 0.7 log increase in CMV viral load. I think we've all probably experienced those patients that come back with a viral load of like 1,000, and it just makes you anxious. You want to resume treatment for those patients. You don't want to see that bad outcome. You don't want to see that admission. But I have kind of held on those. I actually have one case that comes to mind specifically that we did that in. And we repeated a week later. We knew that this was a reliable patient to get CMV PCRs. And it came back and I think it was like 200 some, repeated again a week later, and it was undetected. And so it gave us that trust that, okay, yes, her own immune system really was going to take care of the virus.
I love that story. Thank you. I think that's extremely helpful for the utilization of the assay. And when you think about this particular assay compared to other diagnostics or monitoring methods for CMV infection, do you find that it has advantages over that? Or I know you just said it's another piece or a tool in the toolbox, so I think that kind of answers that question, but anything to add?
I think the thing that I'll add to it is, the specificity is really nice for this. And I think that when I put it together with other pieces, like, okay, someone has an ALC that's adequate, and then they have a CMV T cell assay that comes back and it's good. They may be a high risk recipient, but then you're looking at where their immunosuppression has been and that they've had no rejection. And you start saying like, okay, I feel a lot more comfortable that we can do this. Or on the flip side, Like you and I have chatted about a couple of examples where someone maybe has a right at a borderline response. They're a high risk recipient. Their absolute lymphocyte count is like 0.3. They may not be great at follow up. And those are the patients that it's like, maybe let's just wait, optimize immunosuppression a little bit, repeat this again in 6 months and see where we are. And I think that it provides a little bit more benefit there. And so the other area where I think we'll start to see use is with medication access being such a challenge, especially with a primary medication like valganciclovir losing its manufacturing assistance. There are going to be patients who cannot afford it, just like in our third case. And I think that this could be a really nice opportunity to utilize something like CMV T cell assay to say, hey, do they really still need it, versus previously, saying CMV is really terrible, you may die of CMV, you just got to pay for this medication. And we may still have to say that a lot of times, but we may be able to decrease that use a little bit.
Thank you. Let's see. So can you provide guidance on integrating, and I think your whole talk's on this, but can you provide guidance on integrating these results into a broader care plan for transplant patients, including collaboration with other healthcare providers?
Yeah, absolutely. One of the things that I really value about what my practice looks like right now is in our clinic space, we always have someone from our immunocompromised host ID team that has clinic at the same time. So they're in the workroom, we're talking. Typically we'll kind of sideline them, or if they're not consulted on the patient, say like, hey, what do you think about this plan of care, this, and also incorporating in our transplant coordinators for those patients where maybe we are going to be doing serial monitoring of every 6 months to see if we can discontinue primary prophylaxis. It's really helpful having that multidisciplinary team there to be another person to remind you, like, hey, it's been 6 months since we last checked this. I think we all know that things can get started and, not get stopped, or that a plan of care doesn't always follow through.
Yeah, thank you. And I think this is maybe the last one. So what are the potential implications of utilizing this assay and these results for adjusting immunosuppressive therapy or other aspects of post-transplant management?
Yeah, I think for adjusting immunosuppression, I think it can help break the cycle of, I'm not going to say complacency, that's the wrong word. The cycle of they're doing great, their renal function hasn't really changed, we don't need to minimize their immunosuppression anymore. But yet, if we are thinking about, hey, this is a high-risk recipient who's still on primary prophylaxis, hopefully we can get them off of it at some point. Like, can we decrease their antimetabolite even from 750 twice a day of mycophenolate to 500 twice a day? Or is their lung function adequate for that? Are they on appropriate CLAD prophylaxis? Have their PFTs been stable? Is this something that we can look at doing? I think it just reinforces a look at those two key pieces of information: what opportunistic infection prophylaxis they're on, what's their risk for opportunistic infections, and also what immunosuppression are they on. And so it just brings that question back up to light.
Yeah, that's wonderful. Thank you. I think that's the perfect bow to put on this, especially since we don't have any other questions, but I think that was a really great answer. So Dr. Doligalski, thank you so much for this. I think this was one of the best, meetings on this particular assay that I've ever attended, and really appreciate your time. Thank you all for attending that are on virtually, and I guess we'll wrap this up.
All right, wonderful. Thank you so much for having me. Thanks for all the great questions and discussion.
Thank you.